Okay. Hello, everyone. Welcome to our March Black Maternal Health Caucus meeting. Today, we're joined by Celebrate One here out of Columbus. They do a lot of really good work as far as infant health is concerned, so we're really excited to hear about the work they do through the city of Columbus. I am the SLA for Senator Hicks Hudson. Unfortunately, she's at an event in district, so she might be joining a little bit later. She's not here right now. And then Deja will introduce our group, and then we'll get started.
Thanks so much, Amber, for kicking us off. And thank you all for joining us today for our March Black Maternal Health webinar. And today we have the pleasure and privilege of being joined by the team at Celebrate One. And we're really excited to learn more about what great work is happening here in Columbus under the leadership of Danielle Tong, along with her team, Amanda, Stephanie. Thank you all for being on this call. Okay. Thank you all for being on the call. And Danielle, if you want to go ahead and kind of just go ahead and get started and let us know about the work you're doing here in Columbus. Thank you.
No problem. And Amanda will be working on our slides today. So as Amanda is bringing those up, I am thrilled to introduce Celebrate One to you. My name is Danielle Tong, and I'm the Executive Director of Celebrate One. You'll be hearing from me a little bit today, but you'll also be hearing from two of my colleagues. Amanda Zabala is our Deputy Director at Celebrate One, but you'll also be hearing from Stephanie Bauman, who is the Infant and Maternal Health Manager at Franklin County Public Health, for a wonderful program that they are bringing off the ground. And with that, we can move to the next slide. Thank you, Amanda. So a little bit about Celebrate One. We are a collective impact organization that was established by our mayor in his first term back in 2014. And we were created as a collective impact to address the infant mortality rates in Franklin County, Ohio. But we understand the inseparable link between mothers and infants, and we respect that mother-baby dyad. So much of the work we do is around maternal health as well. I want to bring your attention to this wheel that is also shared on the slide. It shares the 5 components of collective impact. The concept of collective impact was established in 2011 by the researchers that are listed right there on the slide. And it has 5 important components to it. The one that we're going to be talking the most about today is shared measurement. And that one is really the foundation of all of our decision making, really the decision making for anything that we do in this work, but for collective impact is of particular importance. All right, so up next, I am going to share with you some things that truly no one on this call is surprised about, but it is a level setting opportunity so we know where we stand. In Ohio, Black women are 1.5 times more likely to die from pregnancy-related causes compared to their white counterparts. This is the Black Maternal Health Caucus, so you all know that already. That disparity has persisted for some time now. What is also true is that Black women in Ohio experience severe maternal morbidity at more than twice the rate of white women. So we're going to talk a little bit about what maternal morbidity means later in this call, but it is an important indicator of maternal health. And why is this important? Why is talking about this important? Well, of course, we know maternal health outcomes are they're indicators of how well we as a society take care of our neighbors. They tell us how we prioritize the people that we serve, but ultimately it's important because women are people and Black women are people, and our care deserves to be prioritized. Next slide. All right, so before we jump into the meat and potatoes of this presentation, I would like to talk a little bit about definitions that we all need to know. in this field, we often tend to approach it with more general speak, more generalities. And the goal there is because we want to welcome as many people to the table as possible that have as many different starting points as possible. And that is incredibly important. We want to continue to do that. We also want to hold space for nuance, because nuance is really where we're going to start seeing the rubber meet the road with the rates changing. And so by nuance, I mean understanding with detail the language that we use to talk about maternal health. And so these definitions are important, and I will go through them with you. Pregnancy-associated death, of course, is an umbrella term for the death of a person during pregnancy or 1 year postpartum, regardless of the cause. So any cause of a person who is pregnant or within 1 year postpartum is considered a pregnancy-associated death. Within that subset are pregnancy-related deaths, and those are deaths that are caused or influenced by pregnancy directly. And one way to identify this for yourself is, would this person have died if they were not pregnant? If the answer to that question is no, you know that you have a pregnancy-related death. Then there is unable to determine. Those are cases where there just isn't enough information to tell us whether this was a pregnancy-associated or a pregnancy-related death. And then finally, we're looking at severe maternal morbidity, which is an unexpected outcome of the labor and delivery process that results in significant short or long-term health consequences. And what I found interesting in this work is that this piece, morbidity, has happened to so many women, and they don't realize that they are counted among the group of folks with severe maternal morbidity. So that is an interesting caveat. And with that, I am happy to hand it over to Amanda to tell us a little bit more about where we are, what data currently exists, and what it is telling us and what it is not telling us.
Thank you so much, Danielle. So before we jump into the data, I wanted to make sure that we were all aware that legislation does exist that allows for us to see the data as it becomes available. So section 5180.277 of the Ohio Revised Code, which was recently amended and renumbered just last year, indicates that the Pregnancy Associated Mortality Review Board, which was established back in 2010, is required to prepare a biennial report that summarizes the data that they've identified and provides recommendations for how we can prevent future maternal deaths. There's also some legislation coming about that would require this reporting of severe maternal morbidity as well. So I just wanted to point that out, that we are very much aware that there's legislation that does support this, and we're really excited about this. And so we will jump right into what the data are currently telling us. So first is around maternal mortality. So the most recent report that we have on pregnancy-related deaths in Ohio comes from 2020. So the legislation that I just referenced indicated that reports should be done every 2 years, starting in 2020, and we're in 2026 now, right? So the data that we have are a little bit dated, and so it limits our ability to really understand what's happening on the ground right now. So, but in this report, we see that 131 women died from pregnancy-associated causes that year. And when you look at the subset of pregnancy-related deaths, only 35 of those were deemed pregnancy-related or due to the pregnancy itself. And so you can imagine that the issues with small numbers are very real. We can imagine that these data probably aren't available on the local level because of those small numbers, right? 35 deaths out of 125,000 births is a really, really small percentage. But still, based on the evaluations and the investigations in these deaths, we found that infection was the leading cause of death overall, so affecting 31% of those 35 cases. And they found that the most frequently identified contributor to these deaths was inadequate assessment of risk. We also know that when we break out the data by race, that Black women were 1.5 times as likely to die from pregnancy-related causes compared to their white counterparts. And so when we look at these causes of death specifically by race, we see that infections really did affect Black women, maybe at a disproportionate rate. So that includes postpartum genital tract infections, urinary tract infections, sepsis, and probably most notably is the COVID-19 infection that we saw. Thrombotic embolism, so those blood clots, were also a leading cause of death for Black women. For our non-Hispanic white women, it was those mental health conditions like depression and substance use disorder, overdose deaths, et cetera, were most likely to impact white women, followed by infection, cardiovascular conditions, and those blood clot situations. Now, we also know that maternal morbidity is a much more common occurrence. So some estimates say that it's up to 100 times as common as maternal mortality, which is a really important thing to note because it gives us an idea of what is happening with the systems that people are interacting with during pregnancy. And so the most recent state report that we have here is from 2020 with data from 2016 to 2019. And so you can imagine that there's probably been a lot that's happened since that time period that would indicate what's going on in our systems. But this is what we have. And so in this report, it indicates that over 6,000 women experienced a severe maternal mortality event in this time frame. And that blood transfusions were the greatest proportion of these events, accounting for 40% of them. And so really, when we take those out, we have a much smaller number to work with there, right? But we don't necessarily see in this report things that are secondary. What else, if it's not blood transfusions that are the severe maternal morbidity events, what are they? But they did indicate that the most common contributing factor in this report was lack of diagnosis, lack of treatment, and lack of case coordination. And then when we break out the data by race, we can see here that in 2019, Black women were 1.9 times as likely to experience a severe maternal morbidity event compared to white women. And so Black women, not surprisingly, had the highest rates of these events compared to all other groups. And this was true regardless of insurance payer type. So it didn't matter if someone was self-pay, if someone had private insurance, our Black women still experienced higher rates of severe maternal morbidities. And we also saw that these rates were higher in metropolitan counties, a lot like Franklin County, compared to Appalachian, rural, or suburban counties. And then as women age, we tend to see issues rise regardless, but the disparities did widen with advancing age, with the highest being among the 35 to 39 age group. And so it's really important to realize that maternal morbidity and mortality are highly complex issues, and they're complicated by multiple intersecting historic and contemporary social and structural drivers of health. And so Jessica Roach, the founder of Restoring Our Own Through Transformation, produced this web of causation that really is able to walk you through and visualize how historic laws, practices, et cetera, have influenced the various risk factors that impact maternal and infant health. And so if we're not actively measuring all of these different components and we're not connecting them to each other, we can't say for sure why these things are happening. We have a good look at maybe some of the risk factors, but again, if the data aren't timely, if they're not reliable, if they're not fully disaggregated, and they're not linked, then we can't fully manage because we're not fully measuring. And now I'm going to pass it over to Danielle to talk more about those challenges with the data.
Yeah, and Amanda, if I could ask you to actually advance one slide, I'm going to do that slide first and then come back to this one. So Amanda, I think, did a great job sharing with you what currently exists and what gaps we have. In addition to those, we know that current federal funding issues are challenging our ability to collect data on the local, state level, and on the federal level. And that what we really do need are data that get us to a local view of what is happening. Our communities are expecting a local response. We know that what works are local responses, but we do not often have the data that allow us to give precise local responses. In addition, we rely heavily on vital stats data. So vital stats is right now our vital statistics data, for those folks on the call who don't know, are a collection of records for birth and death that are collected by the Ohio Department of Health. And we rely heavily on those. And they are the best source that we have that help us calculate the infant mortality rate and maternal mortality rates. But they do come at a lag. So it doesn't tell us enough information as to what is happening on the ground right now. And in addition, when it's not linked to other data sets, it doesn't tell us why those things are happening. It just tells them that they are happening. They did happen. And the data sets that we do have known tremendous limitations. Some of those data sets are lagged as much as 3 to 5 years. So when we're not able to look at these data, whether it's because the N is super small or because, it's too far in arrears, it really leaves us having to guess at who might be benefiting from the interventions or, whether those are the right interventions. All right, Amanda, if you can go back to that other slide. So we in the infant and maternal health field have a responsibility to get in here and to get some work done to reduce the maternal mortality rate and to reduce the maternal morbidity rate. But we need to be able to answer 3 questions in order to do that. Are we doing the right things? Are we doing the right things right? Are we doing them well? And is anybody actually better off because we're doing those things? And without that kind of data, we can't accurately answer those questions. It causes us to not be able to do the root cause work, to really understand the root causes in order to address them. It leaves us at risk of making racial disparities worse. All right. So you came all this way to find out what Franklin County is actually trying to do about this. And I would be lying to you if I said that we had all the answers and we know exactly how the end is going to turn out. But we wanted to bring you in as early as we possibly can on what we believe are possible solutions to this problem. So let me tell you what we're doing. We have 2 initiatives that you're going to hear about on the call today. One is to build our own local shared measurement system. So if you remember that wheel we talked about at the beginning of the presentation, the shared measurement system is a core component of collective impact. With all of the data gaps we talked about, we really don't have that shared measurement system. So we are endeavoring to build it. And the second project that we're working on that you'll hear about today is a severe maternal morbidity review board, which is extremely innovative and one of its kind in the state. And we're excited for you to hear more about it today. So let's start with the shared measurement system. In order to go back one more slide for me. In order to develop a shared measurement system, you need 4 core components. That would be the common desired outcome, the thing that we want to see move, shared leading indicators, what affects that thing so that it moves. You need an infrastructure. So an infrastructure is really like, where do we hold the data? How do we make decisions on the data? Who is allowed to access the data? Policies around where it's housed, et cetera. And finally, you need a data literacy plan, because the fact is that most people don't feel as though they have the skills they need in order to use this data appropriately. And in order to make sure that it's adopted, we have to make sure that people feel that they can be effective when using the data. Now ready for the next slide. Okay, so this is a concept that I want to share with you, and then we'll talk about how we applied it. We talked about our outcome measure. That's the thing we're trying to move. The primary driver is what is driving that. So what is making that thing move one way or another? The secondary driver gets us closer to those root causes of like, what is really at the root of the primary driver? And then what are those process measures? So I'm calling those process measures, but for all of us, that is, what is it that we're doing? We love to do things. We love our activities. What are we doing to impact that outcome measure? What we see here in Franklin County and suspect abroad is that folks go from the outcome measure, oh my gosh, this terrible thing is happening, to the process. What are we going to do about it? But we've neglected the primary driver. So what is causing that thing to happen? And the secondary driver, what is the root cause? So let's take the example of maternal mortality. All right, so there's a lot wrong here. And I'm just going to go through it quickly because we talked about maternal mortality data in Ohio. It takes us back to 2020. That is the most recent data that we have, is what was produced in 2020. So that doesn't give us good decision making already out of the gate with maternal mortality. At that time, in the good year of 2020, we knew that infection rate was one of the driving causes of maternal mortality at that time. Now, anybody who is here in 2020 could say to us, well, there was this thing that was happening called the pandemic during that time, and that could have been driving that. I mean, sure, maybe it could have. We don't actually have enough data to say for sure whether that was true. We also don't have enough data presently to say whether that is still true or not. So we're just going to go with it. Okay, so what we have available right now tells us infection rates of whatever kind of infection are our primary driver. You should have a lot of questions coming out of infection rate going into secondary driver. What are the infections? What are the things that people are getting sick with? Where are they coming from? What part of the pregnancy process is it happening? Is it during pregnancy? Is it during delivery? Is it in the hospital, say? All great questions, none of which I have answers to, okay? That should lead you into the secondary drivers. Is it the access of care to care that's the issue? The quality, the model of delivery? Is it stress? We don't have any of that information in order to be able to say for sure what caused that infection rate. So if we tried to jump from the information that we have directly into process measures or into doing the stuff that we like to do, we would be guessing effectively and with varying degrees of applied knowledge, certainly, but it still is ultimately a guess, and we don't have the data to confirm or test our guesses. Next slide. Next slide, Amanda. Thank you. Okay, so this is what ours looks like in Franklin County. Now, ours is designed around infant mortality, since that is the thing in our mission. It also is the thing that has the most available data. And because there's enough overlap, we are going to use our proxies the best that we can. We know that our long-term outcome measure is infant mortality rate, and that comes from vital stats, as we just talked about. We see that those primary drivers are prematurity, low birth weight, congenital anomalies, sleep-related deaths. The characteristic that should be most notable to you about those primary drivers is that they've all already happened. We cannot do anything differently on a premature birth to make it not be a driver of infant mortality. And so that means we need to move into secondary drivers. And those here are listed as infant nutrition, maternal health, prenatal substance use, preconception health, all things we all should be familiar with on this call and know as potential drivers of infant and maternal health. We got this both from peer-reviewed literature at the national level and also from studies done at the local level back in 2021. I'm looking at Amanda to nod, or yes, 2021, that are called the perinatal periods of risk assessment. And I'm happy to talk to folks about that offline if you're interested to know how that was done. But that helped us identify what these secondary drivers are. It did not, however, give us a good lead of data sets on how we measure whether we're doing well at those. So that is where our shared measurement system comes into be. And our intervention measures are the doing. Those are the things that we're doing. And that's just a list of things that could flex in and out of here, but truly that's a list of examples. Next slide. All right, so this gets us to the nitty gritty. We've talked a little bit about our thought process and our logic model. We've talked about the data gaps and what we need in order to make sure that we are precise in our actions and precise in how we allocate resources. How do we get to a place where we can actually do this for real and regularly? So the first thing that we are working through is development of a countywide adopted measures set. The best way to say this is that everybody who touches people, not like that, touches families, needs to be able to measure whether those families have pregnancy in the home. And we need to make sure that the way that that is done is consistent across organizations. So we are approaching that in this way. We are asking that every human service organization that serves families make sure that they are measuring pregnancy. They're asking about pregnancy, asking about gestation, asking about family composition in their intake process. So that allows us to know that organizations across our county are measuring pregnancy, and we can cross-tab that information with any other data they're collecting. It increases our visibility to things that are happening to families in pregnancy. But that by itself, while that's awesome, and we're looking very forward to it, it's not enough by itself, because we need to be able to make sure that we know what all of those measures are. What is our field of view in health and human services and in infant maternal health? And so that leads us to a countywide maternal and infant health metrics inventory. What are our health and human services organizations actually measuring? So when it comes time, I'm going to make something up, to talk about pregnancy or early parenting and eviction rates, we know who to go to, what data they have, and how to draw that data down in a way that helps us understand how pregnancy conflates with eviction rates, for example. Our goal from that point is, now that we have our giant inventory, is to narrow those metrics down into those key drivers that we saw on our previous slide. So we want to make sure that we are picking the ones that are most reliable, that have the largest number of families that are reached, that have the most consistent data sources and the closest tie to the metrics we're trying to move. And we want to understand those closely and pull them in. That brings us into our third step in the process, which is infrastructure. So now we've got our metrics, we have the organizations that produce those metrics. Where do we put that data and how do we use it? That's an infrastructure question. In Franklin County, we are extremely lucky that we are building a process across the county that is larger than infant and maternal health, called the Community Information Exchange. And we liken it to electronic medical records, but for health and human service organizations. So if you are accessing services from a food pantry and from a housing organization, those orgs can now talk through this community information exchange system. We're very lucky to have this. However, this can still happen even if this community information exchange doesn't exist, because Ohio has the Ohio Supercomputer System, upon which our CIE is established. So that means everyone in Ohio has access to the Supercomputer Center, which allows for all sorts of high-level, big brainy computing stuff to happen. And the list of that is along the side. So we see cluster computing, research storage, education, software development, research and software engineering, AI, machine learning, all that stuff and more. Once we are able to store our data there, the Supercomputing Center can help us craft how we extract it. We are lucky to have the CIE that is helping us do that, but in a region that does not have access to a CIE can still use the Supercomputing Center. So step 4 then is, once you have this system set up, you need rules on how to use it. And that's the governance piece, and that's the technical assistance piece. We need to make sure that the people in our region understand how to use data. We need to improve our data literacy, and we need to create structure around the governance of use of the data. Next slide. So I talk about this all the time. In fact, I have dreams about this at nighttime. It is something that I am constantly thinking about. And the one question I get from folks is, how long will this take you to do? This sounds like a big project. And admittedly, you know, it's a largish project, but it doesn't have to take as long as we think it has to take. As long as we are consistent and we understand that improvement is iterative and that we are not letting perfect be the enemy of good. And so we have put here a timeline on the process that we are using to get this off the ground. So we're in the middle of this postpartum metrics set right now, of ensuring that our community has a shared way to define and measure pregnancy in a home. On top of that, we are also working through the metrics inventory, which helps us know what we have available to us. And once we have those things constructed, we can start looking at baseline metric collection. So that means that essentially is, what is it that you think is important to be measured? Great. And how are you doing on those things right now? That is your baseline. And you want to have that baseline collected as your foundation for whatever it is you will choose to do next. And what happens concurrently underneath all of those things is technological integration, continuous improvement, and continuous learning. Next slide, please. All right. So what happens if we nail this? If we get this right and we succeed, we become the NASA of infant and maternal health. And listen, our country spends a lot of money to get us out into space looking at glowing rocks, okay? And so if we can do that, we can most certainly do this, and all of our work can have this beautiful mission control center of infant maternal health in all the localities around the state. So I said a lot there. There's a ton to absorb, but there's still more coming at you, because I am thrilled to bring to the stage Stephanie Bauman to tell you a bit more about the Maternal Mortality Review Board, which really does encapture the qualitative pieces of our work. I've talked a lot about quantitative measurement, and what she's going to share with you brings in some tremendous opportunity for qualitative work. Stephanie? I said all of that. I'm very sorry. Stephanie?
Thank you, Danielle. I'm very excited to be here today to get the opportunity to talk to you more about the Severe Maternal Morbidity Review Board, which is a mouthful, so I'll be calling it the SMM board going forward. But just wanted to start by giving you a little bit of background, how we've gotten to the point where we are today here at Franklin County Public Health. We started the conversation in 2023. And actually, when we started the conversation, we were really focusing on a severe maternal mortality review board. But through much discussion and a lot of research, we found out that we were not statutorily authorized to hold the mortality review board. So in 2024, our focus shifted to the the morbidity review board. At that time, then we began looking at other examples, and we're really surprised to find that there were not a lot of other implemented examples to look at, really just a few. And those examples were all statewide initiatives. And so, we're excited at the prospect of really starting a county level initiative review board here in Franklin County. And what we think that will do will give us the opportunity to really drill down into the local data and have it be more timely. So I know both Amanda and Daniel both talked about the lag in reporting time. And so, if we can get to that data sooner, we can make a difference sooner. It just really tells us the story in a better way. And so, Amanda, if you could go to the next slide, please. Sorry, that was where I was. Sorry, I forgot to ask you. You could go ahead to the next one. Thank you. So one of the examples that we looked at was Johns Hopkins through the state of Maryland, and they began a pilot project in July of 2020 that ran through December of 2022. And in that time, they were able to identify and abstract 374 SMM events in 13 birthing hospitals throughout the state of Maryland. And a key component to that was preventability. And they were able to find that nearly 1/3 of their SMM events were preventable. And that was 31.8% of those SMM events. And so they went ahead after the pilot project and expanded that to all 32 birthing hospitals across the state of Maryland. And then eventually that was codified into legislation. You can go ahead to the next one, please. So with the review board, there's certain criteria that they looked for that we would also be looking for to identify cases to pull out. And those recommendations are given by ACOG, or the American College of Obstetricians and Gynecologists, as well as SMFM, or the Society for Maternal Fetal Medicine, which is high-risk pregnancy care. Both of those agencies, they work to set standards in clinical practice, as well as advocate for quality and evidence-based healthcare for women. And so the criteria that makes a case eligible is ICU or CCU admission, and or the transfusion of 4 or more units of blood, and that would take place within the first 42 days postpartum. And so really having that criteria outlined and laid out would help us avoid missing cases that are simply based on ICD-10 or diagnosis codes. You can go on to, yes. So the structure for the SMM review board, we really want to model the structure of this review board around our fetal infant mortality review board here in Franklin County, or our FEMR. And what that is they look at the infant mortality cases here and review them, again, based on the infant deaths, fetal and infant deaths, and then they come up with recommendations and strategies to try to combat those deaths in Franklin County. And what that is a multidisciplinary, multi-agency, community-based program. And so we would do the same. We would look at obtaining designees from different agencies, different organizations in Franklin County, including the health systems, including government agencies like Public Health, Coroner's Office, Celebrate One, and then as well as community-based organizations. And as the FEMR does, we would hold quarterly meetings to review a subset of cases that meet the eligibility criteria. We would have those cases pulled out and ready to review at these quarterly meetings. And then one of the things that is a key component that we focus on in FEMR, and that we really want to focus on in this SMM review board, Danielle kind of mentioned it. They've talked about the quantitative data. We want to look at qualitative data. And so a key part of this review board would be qualitative case interviews. And, we believe by holding maternal interviews as a key part of the process, it would give us more insight into the mother's experience. The interviews could convey the mother's story of what her experience was during the encounter, whether that's during the pregnancy, during the labor or delivery portion, what that experience looked like with local service systems, and give us more information and understanding about those health equities and disparities that we see between the different populations. So what we're seeing between Black women and babies and their counterparts as white women and babies. And you can go to the next slide, Amanda. So for the review board next steps, we did in 2025 start having conversations with the local Franklin County health systems. So like all of the hospital systems, we wanted to start introducing the SMM review board to them because obviously they're going to play a big part in that. And we just at the beginning of this month, we presented this to the Ohio Better Birth Outcome board members. And through all those conversations, we were happy to receive some real positive feedback. And we really hope that those conversations can help catapult us to the next phase in this project. And so next steps would look like entering into de-identified data sharing agreements with these agencies. We would also ask that they identify one person from their agency to do the abstract work, like abstracting the information on those set number of cases per quarter, whether that's a nurse or somebody else within the organization that's going to do that. We also would ask that each agency designate one or more individuals to participate on the review board and then to commit actively to participating in those quarterly meetings. And, we really believe that, again, between having this local timely data and really being able to incorporate the qualitative data into this review board, we believe that this SMM review board can really have some positive outcomes on the Black maternal mom and baby health outcomes. So thank you.
Thank you so much, Stephanie. And so we wanted to make sure that we left you with some things to think about. There are opportunities for advancing this work that we want to bring to the Black Maternal Health Caucus. And really, it's because data is the basis. It should be the basis for the decision making that we do in this space. So the first thing is we want to support the enforcement of Ohio laws that require timely maternal health data reporting. So as Amanda shared earlier, that the most recent data that we have are from 2020. However, there is legislation that requires biannual reporting. So we just ask that standard be held and that we receive this data in a timely fashion. The second are to secure funding to advance data infrastructure. So as I shared here, Franklin County does have already some infrastructure, data infrastructure around the community information exchange. It can always use more funding, but we also know that many communities around Ohio don't yet have access to that. They may not have organizations like this or organizations that are our size that can pursue projects like this. So funding infrastructure and systems capacity is really important. Ensuring that the linkages between data sets and those systems are important. And advocating for those things are incredibly important. And finally, we are looking to advance support for the development of local level severe maternal morbidity review boards. Stephanie did a wonderful job articulating the value of a board like that in our community, and we would love to see that in other regions. And this is simply because, maternal health matters. We are more than just vessels for human life. We are people, we are contributors, we have dreams, and we deserve to live to our fullest capability. So the only other thing that we will leave you with today is that through your career, you will meet folks who will say random things to you, who will have ideas, who will say that they know that something works for certain. And the thing that we will leave you with is to always ask the question of, but how do you know? That is the key to helping us get to root causes. How do you know? And that is all that we have to share with you today. Any questions?
Thank you so much for those presentations, or for your whole presentation. It was very thorough and very enlightening. I will say we have one question so far in the Q&A that I actually believe is better suited to our co-conveners. You might have an answer to this, but if you don't, I understand this is really not your realm. And then I have a couple of questions of my own actually as well. So we'll start with Chanel Harvey's. She asked, what consequences are there for the reports not being made available biannually, like they were mandated? And so I don't know if in your research you saw anything related to that. If not, we will always follow up and then get it back out to you guys.
So I do not know the answer to that question. Amanda, do you know? Or
I do
Stephanie?
not.
Yeah, I didn't think that that was really your realm, but I thought maybe I would leave it to you. And then I do have a couple of questions as well. So, um, Deja, if it's fine, I'll just go ahead.
Yeah, no, you're sorry.
Okay. And then I'll be watching the Q&A as well in case participants also have questions in the meantime. So the first question I had, I noticed towards the end, the SMM board, that was said to have been based off of a project at Johns Hopkins in Maryland. I didn't actually catch the name of the first inventory that you're doing in partnership with the Community Info Exchange. But I wanted to know if that was modeled off of something that you had seen in other counties or other states, just because it seems like a great project, but it also seems like a huge undertaking. And so I'm curious where that model came from.
Mhm. Certainly. So the work that we are doing is not modeled off of another location directly. However, the Community Information Exchange itself, which is the big, large undertaking, has been modeled off of numerous communities around the country. I don't want to say the exact cities, but I know that they are coming from Texas, and I know that one came out of Seattle. But I don't have other examples, and I can get those for you just to make sure I'm not totally wrong. I will tell you that the basis for the system that we're developing does not actually come out of infant and maternal health, and it comes out of a methodology around process improvement. So it is the concept around ensuring that you know what problem you're solving for. And coming into this work, we know that we don't have the data required to answer those questions. And so, what is fueling the development of what you saw today is really, first of all, a community of people who are willing to roll up their sleeves and dig into this with us. But secondly, the driving question of like, what do you have that can help us answer this question? We know that our data and our information from a federal level are at risk. So we saw that there was threats around nutritional data in the SNAP shutdown, and other examples like that. So we believe that it's incredibly important for us to know what data we do have locally and to be able to have local access and control of it in our areas so that we know how to address issues as they come up rather than having to wait for them to cycle through the state and federal government in order to come back down. That answered your question.
It did. And I think pointing out that that initial thought process of, well, we have this methodology for understanding how to identify a problem, even if it's not directly related to this specific topic area, is very resourceful and important, especially considering, like you said, the data is um, sparse and also it's a persistent problem.
Mm-hmm.
So then that actually kind of leads into another question I had, because as you mentioned, like lots of research and lots of human services are um, put in precarious positions, to say the least, as far as their funding and their viability, even within the next few years. And so, does partnering with the community info exchange then shield you from some of that um, funding issue for the project, or is that not a concern for like just
Um,
being able to fund the infrastructure and the manpower behind actually getting it up and running?
so I think number one, the community information exchange does help protect us some from that ongoing funding issue of the program. The other piece I want to say about that is that funding for it does not have to be nearly as expensive as I think it sounds like it is. What we're merely proposing is that our communities be resourceful with us and to figure out how to use what you have in your communities to meet the need of your community. Now, it is going to take funding, and that's really what that last slide was about. It was about how can our state partners and our legislators partner with us in really solidifying the fact that we value data infrastructure, and we know that it is core to finding solutions to the problems that plague us. So that partnership at the state level, I think, will be the thing that ultimately insulates the state from things that are happening at the federal level. What insulates us locally is this traction that has been made through the community information exchange. It also helps that this program is seated within local government, so it does really help have a funding source that is perpetual. Ultimately, we're going to need our state partners in order to help make sure this work has a home and that it persists, because it will have to last, and that's the most important piece.
And I'm sorry, I do have two more questions. I'm not currently seeing anything in the Q&A, um, so one is kind of still following that same train of thought, because I'm also curious, and I know you said that um, infrastructure with the CIE already exists. Um, but for the different partners that you'll have, I mean, I personally live in Franklin County. I know it's huge. There are lots of people here. Is this an optional thing that the Health and Human Services are participating in, or is it like if they're getting funding from the county or the local governments, then they have to participate? Like, how are you mandating that?
We cannot at this stage mandate participation in the CIE or in this data collection process. It is important and incumbent upon us to ensure that we are doing the work to make sure people really understand the value of doing this. The CIE has done a lot of that work for us, because the purpose of the CIE is to link one community service to another to make sure that families are not falling through the cracks. And what we have simply done is said that in the process of doing that, we should be ensuring that we are collecting data that allow us to extract the answers we need to solve our biggest problems. That's a really compelling ask. So if we're doing this, let us make sure that we are getting out what we're putting in. For communities that do not have an information exchange like the one that we are building, the ask is going to be, help us solve our biggest problems. Get our funders on board to help us incentivize the data collection process. I'm not a huge fan of mandates because I don't necessarily think they respect the capacity that exists in various nonprofit organizations. But what it does mean is building relationships with funders to say, hey, capacity building is a really important part of actually solving this problem. How do you fund the work that needs to be done that gets us off of the hamster wheel of providing service and into the place where we are actually solving problems?
And then I'm sorry that triggered another question, so I actually still have two.
I
So
want to say I've got really brilliant people on the call with me too, and I want to make sure that they are also, if I'm talking too much, please jump in.
well, so I just noticed that you mentioned respecting the capacity of nonprofits, which I think is really important in this work. Um, do you are you currently looking at partnerships with the larger hospital systems in Franklin County as well, or is that not a part of this initiative?
That absolutely is a part of this initiative. And our hospital systems are partners in our work in all ways anyway. But Franklin County already has some really important work that's happening that can come alongside this. So Stephanie, you mentioned in the morbidity review board chart reviews that talked about maternal health and about those maternal cases. We already have reviews for 100% of infant deaths in Franklin County from our hospital systems. And we also are participating in FEMUR, which Stephanie also talked about, that the hospital systems are closely aligned to. So those are just some examples. Hospitals are already aligned with the Community Information Exchange, and they are looking at ways to connect their Epic electronic medical records to a community information exchange so that there's information flowing both ways. Our hospitals have been good partners up to this point. And if that is not the relationship that a city has with their hospital partners, That just means the work has to begin at a different place. It is still doable, but it just has to start somewhere different.
Okay, and the last one. So I actually really appreciated you bringing up the PARM report. I personally had not read it previously. I noticed in your brief summary of it, so I don't know how many of them you've read, that you mentioned they started in 2010, but the last one was in 2020, despite a mandate that it's supposed to come out biannually. Um, and then I think you also aptly brought up the point of even though infections were the leading causes of maternal mortality and morbidity in that 2020 report, remembering that COVID was also a thing at that time. And even though we didn't have a name for it in 2019, it was still like rampant. And so I wanted to know, because even though there's this huge gap in data, if you had read any previous report or if in the report you remember them mentioning whether or not that leading cause of morbidity and mortality being infections was a standout and different from previous reports. That could indicate maybe that was the shift, or if this is like a consistent thing where infections have been for the past decade plus a leading cause of maternal morbidity and mortality.
That's a really good question. And to be honest, we did not look back further because those data are so dated. So I think we were both maybe a little bit surprised that infections were so high, especially when we're considering that a lot of them should be really innocuous infections. Like a urinary tract infection should not kill you, in theory. But we were also not surprised in the sense that COVID-19 was so rampant and no one knew what was happening. Vaccines weren't widely available. Care was literally shut down. You know, people could not be there to support their birthing person, either in the hospital or in the prenatal care appointments. And so, yeah, we were really not surprised, but we are very curious to see if this is a continuing trend. Is this something that we're still facing in the state of Ohio? And if so, what is it that we need to be doing in our clinical settings, in our social settings that would support reduced infection rates?
Yeah, absolutely. I think that was a great way to sum that up, and thank you for that answer. Um, Well, I'm still looking at the Q&A. I don't see anything else, and we are at our time. I don't know if you guys have any last words or if Deja, you have any last things.
I just want to say again, thank you so much, Danielle, Amanda, Stephanie, for making time to, talk through us the work that you're doing here in Columbus and just like all the intricacies and the nuances, like you mentioned, and how important it is to consider those things as we continue to try and tackle this issue and make sure our moms and babies are healthy and, like you said, living to their full potential. I will say just before we all leave the call, as everyone should be knowing by now, hopefully, that we do have our second annual Black Maternal Health Summit coming up in 1 month, pretty much less than a month now, April 14th, here at the Ohio State House. It's 9 a.m. to 2. It's like all day event. Danielle is going to be on one of our panels for our provider panel. So thank you so much. And so I just want to make sure to reiterate that is coming up. And I will say, we get emails from people who maybe didn't get a RSVP link directly from our office. That's just because maybe we just, there's a lot of people doing this work. So I just want to re-emphasize and reiterate that please feel free to share that link with anyone else you think will benefit from attending. You all know who's in your community. And so if you think that that's something that they would benefit from being at, please share it. It's not exclusive invite or anything. It's open to the public. We want as many people to come out as possible to like hear more about, really there's so many people across the state really taking this issue head on. And we want to make sure that the legislature is here. They'll be here that day to, hear from you all and hear the work that you're doing in their communities to improve the health and well-being of families. So I just want to reiterate that. Please join us April 14th. After this message or after our call, I will also resend out that RSVP link that hopefully most people maybe on this call have gotten. But again, share that with your friends as well. So, because I might not be able to get to everybody. So please just share it and encourage your friends to attend. We'd love to have you all and see you there and get together and come together in person and, just that network of support for the work that, everyone is trying to do here. So that's
And
really all or Amber, go ahead. Sorry.
No, I apologize. I didn't mean to cut you off. But Director Dawson, we can see your hand is raised. I actually do not know how to unmute you.
I think
I'm
maybe
not seeing the options that you have.
I'm trying to figure it out right now. Sorry.
Oh, you're okay.
She's just listed as Angela Dawson, Ohio Commission on Minority Health, if that helps.
You should be able to talk now. Sorry about that.
Sorry about that. I wasn't sure. Are you able to hear me now, Miss Kidd? Just what I had typed this. I was typing in. I'm in my car, so I'm trying to be safe. Uh, so just wanted to say tremendous presentation, just excellent. Thank you all for all of the work that you do, for pushing the need for that continued mandatory, necessary access to data. Is just, we have to know that this is unacceptable. What is not measured is not funded. And we have to be persistent, steadfast, and immovable in this season and future seasons because our mothers and our families are depending on us. And it is not that we do not get exhausted from this work, but I want to tell each of you to remain encouraged. Do not back away. Do not be still. Do not turn around. We are on track to make a difference. So thank you all so much. We appreciate you.
Thank you, Director Dawson. That means a lot. I very much appreciate your feedback and your support. And thank you for even coming to listen to us today. This won't be the last that you hear from us on this topic because we too believe, we very strongly believe that this is where we will see the tide change. You know, when you are, applying your resources in a precise way, you will start to see the results that you.
And let me say this,
Mhm.
we are absolutely collectively making a difference. The return on investment is obvious when we are reducing neonatal admissions. We know those on average are 280,000 admissions. So whether it is counted and the data is aligned the way we want it to be, we know that we are making a difference and a significant return on investment for this state. So stay the course, ladies. Don't be moved. Thank you so much. It was awesome. Thanks so
Thank
much.
you,
Have
Dr.
a
Dawson.
great day.
Well, thank you again, everyone. Thank you, Director Dawson, for all the work you do as well, and being on the call today. And so thank you. I mean, if anyone has any follow-up questions or anything, of course, you can always reach out to Amber or me and Senator Hicks-Hudson and Senator Ingram's offices. We'll be sending out the recording of this meeting once we get that finalized. And then all of our meetings are always uploaded to the Ohio Senate Democratic YouTube webpage. So if you ever want to look back on other meetings that we've had, they're all uploaded to the YouTube as well. So if there's any final things, if not, thank you all for being here today. And we really look forward to seeing everyone April 14th, less than a month, at the Black Summit.
Yeah, thank you. And please invite the public. The public is welcome. We want all of our constituents to attend.
Thank you.